next presentation, and it's a big word. It's a big word, neuromodulation. It's a word that might sound a bit intimidating, but trust me, it's the kind of innovation that can truly change lives. Now, this keynote is titled Innovations in Neuromodulation and Mental Health. Think of it as science teaming up with cutting-edge technology to directly impact the brain, to bring relief to patients who may have run out of options with traditional therapies. And who better to guide us through this talk than Dr. Jean-Baptiste Belge, Director of Neuromodulation at Brain NM Clinics, and of course, Edward Schiettecatte, Founder and CEO of Brain NM Clinics. These two are at the forefront of this groundbreaking field, and they are here to share with us how their work is giving patients hope in changing their lives. So whether you're just curious about the technology, the science, or just about the possibilities it opens up for mental health, you are in for a definite treat. So please give these two gentlemen a very warm round of applause.
Good afternoon. My name is Edward Schiettecatte. I'm the founder and CEO of Brain NM Clinics. And I will be presenting together with Professor Dr. Jean-Baptiste Belge about Brain NM. So about Brain NM Clinics, I would like to start the presentation with the story of Brain NM. So this is my son Nathaniel. My son was born in 2009 and suffers from cerebral palsy. I started my career on Wall Street in 1997 and 2009. My life changed and decided to do something about it. And this was the beginning of Train NM and also the beginning of Brain NM. You see here my son Nathaniel, he was 4 years old. He wasn't able to speak. He wasn't able to make noises. He was only crying. But one single session of TDCS, of transcranial direct current stimulation, changed his life and our life, and he started talking. So we'll listen to Nathaniel.
Hi, Natty.
Hey. Hey.
Hi.
Hey.
Hi.
Hey.
Hi, Natty.
Hey.
Hi.
So this was a defining moment for us because we were able to communicate with Nathaniel, and also the belief that if we were able to bring all these different technologies under one roof, that we would be able to change not only his life, but also other people's lives. So this led us to Train NM. Train NM is a leading outpatient neuro rehab clinic focused on intensive rehabilitation using robotics, using VR, neurogaming, and non-invasive neuromodulation, focusing on the physical side. And from there, we developed Brain NM, which is focused on mental health. So today, we are active with Train NM and Brain NM in 3 locations in 2 countries. So we have 2 clinics in Belgium, in Antwerp and Ghent, and since this year also a clinic in Amsterdam. So the technologies that we use at Brain NM are the following. So we use TDCS, which you see on the right-hand side at the bottom, transcranial direct current stimulation. We also use RTMS, repetitive transcranial magnetic stimulation, which you see at the bottom left with neuronavigation. Then we also have deep TMS, which is deep transcranial magnetic stimulation, which you see on the top left side, and then also TPS, or transcranial pulse stimulation, which you see on the right-hand side. These technologies are either CE or FDA approved. We are also a center of excellence for TPS. TPS is a technology that's CE approved for Alzheimer's, and we are one of the first clinics in the Benelux to offer this technology. So here you can see the indications that we treat at Brain NM. So you see that we treat major depressive disorder, post-traumatic stress disorder, and OCD, anxiety, bipolar, addictions, nicotine addictions, chronic neuropathic pain, etc., and also a number of neurological indications. But let's say that today the focus lies mainly on the psychiatric disorders, such as MDD, PTSD, and OCD. We have a very impressive medical team. So our chief medical officer is Professor Steven Lores. He's a neurologist at the University of Liège who founded the Coma Science Group. He's also the head of the Cerveau Brain Research Unit at Laval University in Canada, and also a visiting professor at Harvard Medical School. Professor Boon is one of our board members. He's a former president of the European Academy of Neurology and a professor at the Eindhoven University of Technology. And Professor Belge, who is here today, he's our director of neuromodulation. He's an interventional psychiatrist with a PhD from the University of Antwerp and Radboud UMC, and the head of the clinic at the University Hospital of Liège in Belgium. Three other members: Julien Kremer, neurologist; Professor Van Buiten, a pain management doctor; and Professor Van Kelster, neuropsychologist. So this is our medical team at Brainum. Two scientific advisors, Tony van Havenberg, neurosurgeon, and Professor Collignon. But I'm here today to tell the story of Noémie. As I mentioned earlier today, Noémie is here with us. She came all the way from Belgium with her family. She's been suffering from severe depression since COVID. And a few months ago, there was an outcry on Belgian national TV where she said that nobody would be able to help her, that she could not be treated. So we decided to treat Noémie with an accelerated deep TMS protocol, about 60 sessions of deep TMS in combination with neuropsychology, in combination with some physical exercise with gym, and also neuropsychology, and the results were very good. And Professor Belge will talk more about the science in a few minutes. So I would like to present also the video, because everything was covered on Belgian national TV, to follow the story of Noémie at Brainum.
Niet goed met mij. Ik word de hele tijd weggestuurd van de een naar de andere plaats. Er is eigenlijk niemand die echt mij kan helpen. Ze altijd zeggen van ja, oké, je kunt hier niet terecht voor je eetstoornis, hier niet voor je depressie. Dus ja, eigenlijk ben ik een beetje radeloos, of hopeloos ook.
Noémie is 17. Al sinds ze 13 is ze depressief. Ze wordt gepest en wil niet meer leven. En ze stopt daarom ook met eten. Ze zoekt wel hulp, ze wil voor een langere tijd opgenomen en behandeld worden, maar ze botst op lange wachtlijsten. Wordt op heel wat plekken weggestuurd omdat haar problemen te complex zijn of kan er maar voor enkele dagen terecht. Deze week is ze nog met spoed opgenomen in het ziekenhuis, omdat ze veel pijn had van haar maagzonde. Via die zonde krijgt ze toch net genoeg voedingsstoffen binnen om haar in leven te houden. Maar zodra de pijn weg is, zal Noémie weer naar huis moeten. Ze ziet het niet meer zitten en heeft daarom euthanasie aangevraagd voor ondraaglijk psychisch lijden. De reportage raakte veel kijkers, onder wie ook Edward Schiettecatte. Hij is de CEO van Brain & gespecialiseerd in behandelingen voor onder meer depressie.
Ik was echt wel persoonlijk geraakt door haar verhaal. Ik heb het dan direct besproken met onze dokters om te kijken van ja, kunnen wij Noémie helpen? En het antwoord was positief.
Concreet krijgt ze hier vandaag een eerste behandeling met deze helm.
De helm al eens op jouw hoofd zitten.
Dus dat gaat ervoor zorgen door dat neuroplastisch fenomeen dat er opnieuw verbindingen ontstaan, beter worden. Wat dan op termijn dan een antidepressief effect heeft.
Nu is het tijd om de therapie af te bouwen.
Voor mij voelt het wel goed eigenlijk. Ik ben natuurlijk nog lang niet beter. Het is ook geen wondermiddel, want vele mensen denken dat het echt een wondermiddel is. Maar ja, het heeft mij wel een beetje geholpen, vind ik zelf. Ik had dat niet gedacht, mijn mama ook niet. Maar kijk.
De complexe cijfers en grafieken liegen niet. In de afgelopen weken heeft Noémie aanzienlijke vooruitgang geboekt in haar behandeling. Eerst was er sprake van asymmetrie in haar hersenactiviteit, typisch voor depressieve klachten. Maar dankzij de therapie is dat sterk verminderd. En er is ook een daling van haar depressiescore.
Toen Noémie met de therapie is begonnen, waren we aan
tussen de 58 punten en de 65 punten. En nu hebben we eigenlijk een daling tot 44 punten, 40 punten. Dat is dus altijd een beetje fluctuerend in functie van wanneer je die vragenlijsten doet. Dus de bedoeling zou zijn dat we toch nog wel wat verbetering wensen te bekomen. En vandaar ook het verder zetten van het protocol dan in een maintenance versie.
Ze had geen sociaal leven meer en ging niet naar school. Maar nu heeft ze haar eerste smoothie geproefd, zit ze in haar puberteit en heeft ze ook weer een doel voor ogen.
Ik ben gestart met mijn eigen bedrijf, Pro and More. Dus ik maak eigenlijk alles voor mensen met zondes. En ik moet er nu al 60 zonnepads maken. Dus ik ben wel druk bezig.
So with this, I would like to give the floor to Professor Belge, who will give some more explanation about the science behind neuromodulation.
Okay, thank you very much, Edward, for the nice introduction. So indeed, I'm a Professor Belge. I'm a professor at the University of Liège. I'm specialized in neuromodulation. I do also a lot of research about neuromodulation, non-invasive, especially, but also invasive deep brain stimulation. So these are my associations. So I will do a deep dive into the neurobiology of neuromodulation because I believe it's very important to increase awareness about this technology because it can really save lives, as we did see. So first, I'm a neuroscientist, so I talk a lot about the brain. So first, if we want to do neuromodulation, it's a focal technique. So with neuromodulation, you want to stimulate a specific brain region. For example, in depression, maybe you want to stimulate the orbitofrontal cortex or things like that. But before you can really choose a region that you wish to modulate, you really have to know the neurobiology of a psychiatric or neuropsychiatric disorder. And so there are many ways to do that. One of the most advanced ways is the use of fMRI, functional MRI. If we use functional MRI, the brain of each and everyone can be divided in many functional networks. Yeah, you can divide it in 3,000 functional networks. But the best way to reduce the complexity is dimensionality reduction. So dimensionality reduction is you reduce the functional brain networks in three main brain networks. So you have a default mode network, a very important network, especially for self-referential processing. Then you have a cognitive executive network, very important for complex cognitive tasks like maybe listening to this presentation. And then you have the salience network. So the salience network, also very important. So it will capture new information in the environment and then deactivate the default mode network and activate the cognitive executive network to interact with the external stimuli. So this is very important, all these networks that are composed then also by specific regions. For example, cognitive executive network, you have a part of the brain that's called the dorsolateral prefrontal cortex. And the interaction between these networks or the disinteraction, the disconnectivity can create indeed psychiatric symptoms. So if we know which circuit is aberrant, we can then modulate it. So this is, for example, a little picture, a description in a pictorial way of an MDD patient, or what we can see in an fMRI scan of an MDD patient. It's based on a huge meta-analysis of the Enigma consortium. So one of the main alterations we can observe is, for example, a decrease in connectivity between the cognitive executive network and the salience network. But there are other dysfunctions also present. So then what can we do if we want to treat a depressive patient, a patient with a diagnosis of MDD with neuromodulation? So RTMS, the ED behind RTMS, you have a magnetic coil, which is quite potent. It's a very potent magnetic field. And with that magnetic field, you can actually stimulate a brain region. So, for example, here you see a picture of the left dorsolateral prefrontal cortex, which is stimulated at high frequency, at 10 Hertz. And that's actually a protocol that is FDA approved for depression. So what you do is you do one session a day, 5 days a week 6 weeks, 30 sessions. And you stimulate the brain region. The effect on the brain region will be a neuroplastic effect, so the activity of the brain region will increase, which is interesting because, as you saw, there is an hypoconnectivity in this left cognitive executive network in depression. So as you can see in this graph, it was published in Lancet, you can see indeed that RTMS is better than placebo, and it's better than sham. And if you look at a normal RTMS protocol, indeed we can see that it's a response remissions rate around 30–40%, so it's equal to an antidepressant. It's very important to know that now in the Netherlands, it's also a treatment that is reimbursed. And when is it reimbursed? After 2 antidepressant trials. And then it's better to use after that RTMS because it's then 6 times more efficient than normal antidepressant medication, was also published in Lancet lately. So then we can optimize such a protocol because when you do high frequency stimulation of the left dorsolateral prefrontal cortex with a normal protocol, it takes a lot of time. It will take you 36.5 minutes, maybe 90 minutes. What you can do, you can change actually the magnetic stimuli and you can transform it in a theta burst. A theta burst is a specific magnetic wave that mimics brain rhythm. And if you do that, you can actually reduce your session time to 3 minutes or 9 minutes and 40 seconds. And you can see indeed that if you compare the 2 techniques, the long one and the short one, the 10 Hz against the 50 Hz theta burst stimulation, it is indeed as efficient. So you should use theta burst stimulation. Then what you also can do, normally you do 1 session a day, but if you want to optimize the treatment, you can do many sessions a day. That's very important for neurobiological reasons because you will increase the neuroplastic effect. That's called metaplasticity. Further, and that's something we do also at Brain NM, you can actually personalize the treatment using functional magnetic resonance imaging. And what you will do is actually, there's a lot of evidence about this, you can actually stimulate a very specific region of the left dorsolateral prefrontal cortex. And this region in an fMRI scan will anti-correlate with another region of the brain, which is called the subgenual anterior cingulate cortex. And when you do that, there is a lot of evidence. When you do that, the response rates will be higher. And when you will stimulate using an fMRI this very specific region. And then you can combine all this. It was done by Stanford. We are doing it now also. It's called the SAINT protocol. It's very famous. It's FDA approved. It's commercialized. What they did 10 sessions a day, theta burst stimulation with fMRI. They did it 50 sessions in 1 week, and they have remission rates of up to 90% after 1 week of treatment. So this is very important because with medication you will not obtain such results. So further, other techniques we use in Brain NM is Deep TMS. So Deep TMS, these are the helmets you see. And that's Noemi, that's me. Okay. And with Deep TMS, the difference is, as you can see, it's a much larger magnetic field than with RTMS. It will also penetrate deeper in the brain. And you have actually many different coils. You have the H1 coil. It's specific for depression. It will stimulate the left and right dorsolateral prefrontal cortex. You have the H7 coil. It's explicitly made for obsessive compulsive disorder. It will stimulate the ventromedial prefrontal cortex, anterior cingulate cortex. And then you have the H4 coil, which will stimulate the bilateral insula. You can use it for smoking addiction. All of these helmets, devices are FDA approved, neuroengineered in Israel. So, for example, when you use the HACET coil, the H1 for depression, you have splendid response rates up to 81% after 30 sessions and a remission rate of 65.3%, much better than medications. You can also accelerate such treatments many sessions a day to make it shorter for the patient. That's an example. So indeed with Noemi we had asymmetry in the brain. We did a QEEG and an improvement of that asymmetry after Deep TMS of the both dorsolateral prefrontal cortex. So this specific helmet, as I said, is a specific one for OCD. So it's very important because OCD is very resistant. You know, people are really suffering of this You can do cognitive behavior therapy. Many medications can be tried, but often you have to do something else. And then in Belgium, you can do deep brain stimulation. It's very invasive, so it's very important to have other options. And with the H7 coil, you will obtain, with these very resistant patients, very nice results with response rates up to 45.2%, which is extremely nice, much better than sham, also than placebo. RTMS is also very important because you can use it for Alzheimer's, so that's the same idea. So I will show you this study. For Alzheimer's, for example, this was a study published in Brain, a very important study. You can stimulate a very important cognitive hub. It's called the precuneus cortex. It's part of the default mode network, which shows alterations early on in Alzheimer's. What they did 10 sessions, so 2 weeks of treatment, and then they did 22 maintenance sessions, 1 session a week during 22 weeks. And what they did observe, and this is very important, that the patients who did receive in this randomized controlled trial real stimulation had first a stable performance of a very specific cognitive scale. So there wasn't a decrease in cognitive performance, which was the case in the placebo group. And there was also a better performance in these 3 specific cognitive scales. So RTMS is indeed a very interesting option for Alzheimer's, and we are treating many patients in our clinics. I will skip that, it's not important. So one of the newest techniques we propose, and we are the only one, I believe, in Europe at the moment, in the Benelux, is TPS. So TPS is another technique. It's ultrasound based. It's developed by Storz in Switzerland. And with this ultrasound technique, so the nurse is showing here what he is doing. So he's stimulating the brain with an ultrasound. And this ultrasound will penetrate deeply in the brain until 8 centimeters deep. And with that, you can stimulate actually many regions. And for example, for Alzheimer's, we will stimulate temporal cortex, bilateral, parietal cortex, the frontal cortex, and also the precuneus cortex. And this is a very new technique. It's non-invasive, and it can indeed improve cognitive function, and also, it can also slow the decrease of cognitive performance. It has a neuroprotective effect. Latest publication in the journal Brain Stimulation. So in the journal Brain Stimulation, it was also demonstrated that it could have a very positive effect on neuropsychiatric symptoms like apathy and depression, as also on the cognitive rating scales. So thank you very much for your attention, and I'm open to questions.
Thank you so much for this presentation. It was really insightful. You mentioned something about it being reimbursed in the Netherlands.
Yeah.
After 2 rounds of using antidepressants.
Yeah.
Do you know why they still prefer antidepressants? Because it sounds
Yeah.
much less invasive.
I honestly don't know, because there is a lot of evidence to use it in first line. So in the States, they often use it also in first line. I don't know. No, they are a little bit conservative also in the Netherlands. So maybe that's something. But I'm not really aware why they don't use it in first line. So in private clinics, often it's done. But when you enter the normal healthcare system, you have to follow these very strict rules. But I myself, I treat a lot of patients, with mild or moderate symptoms, indeed with RTMS as a first-line treatment, because you have no side effects, antidepressant sexual side effects, weight gain, it's enormous, it's terrible. You can use RTMS, it's a better option, I believe. Yeah.
And it also sounds like there's much more scalability in this, because you can have multiple patients sitting next to each other, all being stimulated at the same time. Yeah. And it sounds like a real solution for the mental health issues we have nowadays. Is that something you guys talk about with maybe the LHV, so the Dutch local general practitioners society?
Right now, we just started up in the Netherlands. There are already a number of clinics active in the Netherlands. but just focused on treatment-resistant depression, and we will go further than that because we also have neurological patients, so we can also apply our technologies to go further, but then without reimbursement. Yeah.
But yeah, indeed, the idea is to scale up and to come even to Dubai soon, and to propose fast, effective treatments, personalized with functional imaging, functional EEG, to really help this patient suffering. Yeah.
Okay, thank you so much.
Yeah.
Thank you.
Thank you for your presentation. My simple question is, in order to control the Alzheimer's disease, is it you are using for mild or moderate or severe?
For depression?
For the Alzheimer's.
For Alzheimer's, light and moderate.
Likely moderate.
Yeah.
Suppose if it is severe Alzheimer's, what they have to do?
Yeah, it's, you know, you could, TPS and RTMS, you could use it for a severe form of Alzheimer's, but in the studies, in the meta-analysis, the gains you will obtain for cognitive performance, it will be very, very low from a statistical point of view. So to obtain good results, you really should focus on minimal cognitive impairment, light forms of Alzheimer and moderate forms of Alzheimer. But yes, if a patient wants, and if a patient, you can indeed try to treat a severe form, but the results will be suboptimal.
So that means the mild is best to initiate your disease, right?
Yeah, yeah.
Thank you.
Yeah, pleasure.
Hello, this is very interesting. I wanted to know, since how long are you practicing this, and does it have any after effects, maybe 6 months, 1 year along the line?
Yeah, the longitudinal effects, you mean?
Does it have any after effects?
After effect?
Yes.
Yeah. Do you mean side effect or the lasting effect of the treatment?
Side effect.
Side effect. So that's a very interesting question, and that's also why we love neuromodulation. So the main side effect with neuromodulation, magnetic stimulation, is a headache. You have a light headache. Then there is a small risk in a non-epileptic patient to have an epileptic seizure. Is a risk of 1 on 300,000 patients. It never arrives. It's you know, a theoretical risks. And that's everything, you know, that are the main concerns. It's a very well, it's a very well supported treatment. And then it's also a treatment that when you do a treatment for depression, when a patient is in remission, you will obtain a stability for at least 1 year, you know. So it's very nice also in a longitudinal way, you know. Relapse will decrease. Yeah.
And what happens after the 1 year?
Yeah, there is a follow-up, but I mean, when you look in the studies, the risk of relapse is like 13%, which is when you stop the treatment. Then we do maintenance treatments and things like that. But that's what I mean.
So does it help OCD, bipolar disorder, and how long are you doing it since?
So I myself, I did it a long time also in research, so like maybe 10 years, but the clinic, the neuromodulation clinic Edward founded is 1 year and a half.
1 year.
Yeah.
1.5 years. But we've been treating patients, neurological patients with TDCS, for example, for hand-arm rehabilitation or cognition or aphasia, already since 2017. But the RTMS, deep TMS, and TPS is only since 18 months.
I see.
But very intensely.
And this is only in the Netherlands or even other parts like Dubai or other places?
Yeah, so now we are in Amsterdam and in Antwerp and in Ghent, so in Belgium and in the Netherlands. And indeed, after that, there will be a scale-up in other countries also. For example, we are looking at Dubai.
Thank you.
Thank you.
Yeah, thank you for the talk. I'm a neuroscientist from Japan, but I'm not familiar with neuromodulation. In Japan, some clinics try to personalize the protocols, like the location of stimulation based on the quantitative EEG. Have you tried any personalized approach like that?
Yeah, absolutely. So you could use a QEEG to personalize, But you know, when you look a little bit in literature, there is not a lot of evidence about doing it. So I believe the most evidence-based protocol is the one I showed about treatment-resistant depression. But you need a functional MRI, which is in Belgium and in the Netherlands not so difficult to obtain. And then you can indeed, you know, localize very exactly this location of the left DLPFC, which anticorrelates the most with the subgenual anterior cingulate cortex. So you can do that. Also for OCD, you can do some stuff. For example, you can do an fMRI task-based. You can do a Tower of London task. And then you will have a specific activation in the OCD patient in a very specific part of the pre-SMA. And then you can also inhibit actually this region. So yes, you can do personalized protocols, but it's mostly driven by fMRI. And maybe there are new developments. You have kernel and things like that. Maybe we'll use that. But indeed, it's for each patient is another localization indeed.
Interesting. Thank you.